同時開緊會嚇。就
I would like to say that we will end the meeting at 12:30 because at that time the electrical building will have a fire drill. So let's use the time more wisely. Alan, for part 3, I would like to focus on the elderly health outreach team situation, because every year for 14-15, 53.1 million has been allocated for 56 people, including doctors and nurses, under the visiting health teams. But according to the audit results, in 2013, for example, if you refer to para 3.2, (3.5), 3.6, it seems that the audited situation is that if you look at 3.5, for a small elderly home with only 9 people, (15) HPAs were conducted in 2013, but one of the 15 HPAs was attended by only 1 elderly, and each of the remaining 14 HPAs was attended by only 2 carers. And for the other programs, carers should also attend, for example, exercise for frail elderly campaign. But no elderly is actually attended. And then only one self-financed audit noted that in the case of one self-financed social center, 10 HPAs were provided repeatedly, but with very low attendance rate. So I don't think the impact of having such visiting health team is very obvious. Since the establishment in 1998, no review has been done on the visiting health teams. So I'd like to ask the director or the secretary. For part 1, in the morning, we can see that in all 18 districts, the Department of Health has been running the elderly health centers with a shortage of manpower, and therefore the demands of elderly people are not met. For first assessments, you have to wait for 9.5 years in some of the districts. So for the visiting health team, if the effectiveness is so limited, perhaps you can move some of those manpower to the elderly health centers to better make use of our resources. If you refer to page 29 of the Chinese version, report 63, there's 1 senior doctor, 5 doctors, 17 nurses, and 30 registered nurses, 9 motor drivers. If you redeploy such people to the elderly health centers, it would certainly help. So how does the director or the secretary review the visiting health teams so that 53.1 million injection can lead to higher level of efficiency to serve elderly people? Our director? Chairman, the purpose of setting up the visiting health team is to educate institutions on how to care for elderly people, and with comprehensive assessment, we can see how we can control infections, drug management, and prevent falling among elderly people. This is not targeting individual health. It is about institutionalized services. And the carers can also receive knowledge to take care of the elderly. So on a regular basis, we will carry out such health education work. For smaller institutions, they have limited resources and manpower. Perhaps they need even more assistance. For example, every time we visit for 45 minutes or so, and the content will include Parkinson's disease, cataracts, tuberculosis, food poisoning, drug safety, respiratory tract infections, nutritious issues, colorectal cancer, hypertension, skin problems, health of the limbs, and other health-related issues. So if we see that our facilities are not sufficient in a certain institution, we'll make more frequent visits. Other than the training for the institutions, we also target elderly people, and sometimes the elderly would attend some of our activities. Sometimes the carers would also attend. And more or less, all the activities are about health. If no carers are present, originally the targets would be the elderly, but sometimes they are too tired or they don't feel like coming out to the activity room. They may not attend all the activities, but we have reminded our colleagues that we do accept the audit report. On a regular basis, we will step up our work, focusing on different institutions. The non-RCHEs will also review the content of the training courses. For example, cases referred by the CPC, contagious disease outbreak, or drug incidents. So this is not just about health education and training. There will be public health issues, infectious disease, and food safety incidents. And institutions with SWD licenses, if there are any problems, they will also be referred to us, and we will help follow up and educate the staff and also carers on how to improve the measures. Director of Health, according to 3.12 of this report, agrees with the audit's proposals. She has said that DH will review the mode of operation of the VHTs in conducting HPAs with a view to introducing service improvements. Can you offer more details here? How are you going to do the review? How are you going to review the mode of operation of the VHTs? How are you going to introduce service improvements? That is 3.12. On the list of institutions, on a regular basis, SWD has a list of RCHEs, and non-RCHEs will be covered by our email correspondences, and we will see where we can step up our services. And also in terms of the content of health education, in the past, on a regular basis every 3 months or towards the end of every year. Our colleague will review the content of health education and see if they need to be updated. There are golden rules that will apply at any given time. But now, on a systematic basis, we will follow up on the content of each and every list and see if there's a need for updating. For some special items, for example, there is this event to remind the staff that elderly people need their carers, especially if the elderly person is becoming more frail. We need to remind them to pay more attention to elderly safety and at the opportune time do a health check before health education activities can be conducted. Ellen? Chairman, I think I'm more concerned about 3.5 and 3.6 of the audit report and the picture painted here. For the VHTs, when they want to share with elderly people on self-care or how the carers should care for their elderly people, it seems that attendance rate is very poor. On the surface, we may have this conclusion that it is a waste of the 62 people, including doctors and nurses, in the VHTs. So I would like to listen to the director concerning any schemes you may have to target such promotional activities with very low attendance rate. How are you going to promote them more effectively so that the work of the VHTs will not be wasted?
For our CHEs, the number of participants is related to the size of the RCHEs. We understand, we agree that if the RCHE is a small one, maybe some adjustment can be made. But as I've said, we're not just looking at the number of residents. If the RCHE is small and the staff number is small, they still need advice. When we liaise with the RCHEs and the non-RCHEs in the future, we would enhance our service provision by going to bigger RCHEs. Or do you mean that before the VHT goes there, are you going to put up some posters or make more phone calls, or what? Can you be more specific? I'll ask my Assistant Director, Dr. Lee, to say something about this. If it's now CHE, well, our VHTs go to all our CHEs annually. We've had an assessment on the training needs. For example, the weakness of the staff, we will provide training specifically for them. We'll come up with a training plan for each our CHEs. For non-our CHEs, in the past, we would collaborate with the elderly centers or EHCs. We would organize the number of visits in cooperation with these centers and our non-RCHEs. In the future, we would be more proactive in ascertaining the needs of the elderly or the carers so as to adjust the frequency or number of visits. In 3.10, the audit has pointed out that there have been no review for 10 years. According to Dr. Lee, you are going to review that? Yes. I have a last question for part 3, 3.14. In 2013, the VHTs have visited 564 private RCHEs to review their health records. According to the audit report, the so-called non-private RCHEs, that is those subsidized by the government, will not be subject to the review of health records, because we are talking about very detailed health records, and the audit commission has asked the director of health to review this practice of not reviewing non-private RCHEs, and also on computerization of the health records. The director of health has agreed to this recommendation. So in the future, when you visit the 195 non-private RCHEs, i.e. subsidized RCHEs, you are going to check the health records and how the records are kept in the computer system and so on. Is that correct? Well, here's some background information. Back in 1999, some 40% of private RCHEs have kept personal records of their residents. The other did not have sufficient records kept. And then we came up with a standard practice of health record keeping, and we try to promote this to private RCHEs. That was for private RCHEs. Therefore, it's subject to regular review. We agree with the recommendation of the Director of Audit. In the future, we would implement an inspection system for non-private RCHEs. This will be done annually, depending on the health risk. We're also going to take samples for inspection from private RCHEs. Mr. Ng Leung Sing, what about other members? Mr. Ng, you're on part 3. Can I also say something, ask questions about part 4 after that? You're second in the queue, Mr. Ng. Thank you, Chairman. I think I have to declare, like the Chairman, that we are elderly people, but there's no specific personal interest involved here. I've heard some of the replies from the Secretary. At the Electoral Commission meeting, we are talking about resources. I think if no funding is approved, the promises made by the Secretary cannot be realized, even if he agrees to make promises. So I share this view. At the Electoral Commission meeting, we were talking about resource-related issues. Please return to this report. I think the Secretary is more than capable of speaking for himself. 3.5, 3.6, 3.7.
健康推廣咧，為長者搞嘅咧，已經係
For health promotion activities, in 2013, quite a big number of activities were conducted. 9,100 odd activities were conducted. In terms of the number, is quite a feat. But some are more popular than others. Some are less popular. for more than 10 occasions, 10 HPAs, only one elder attended, and in some other cases only the carer showed up. We're talking about a small number of health promotion activities among the 9,000 odd conducted. And my question is, after 2013, did you try to compile the statistics? Did you try to find out the response of the participants so that after 2013, in 2014 and beyond, you would arrange more popular health promotion activities and discontinued the less popular ones? Have you done this after 2013? Director, you did explain the approach, but perhaps you can somehow recap here. Well, we keep statistics because after a visit, our staff will have to come back and report the number of participants. The highest attendance was 92. The average is 13. And this is about RCHEs. For non-RCHEs, the number is 92, and the highest number is 130. That's the figures gathered by our visiting staff. We'll continue to review how we can provide better programs. Well, this is educational in nature, right? All right, 3.7, contents of health promotion activities. Among the 160 topics, 70 of them were produced 10 years ago, so that they had been in use for 10 years. Were those 70 really popular? Have you got information to indicate their popularity? What about the newer topics? Are you going to use them for up to 10 years as well? And do you have a policy of conducting a review after a certain number of years? Were the contents aimed at preventive healthcare practices, for example, playing Tai Chi and exercise, suitable for the elderly? Some are publicity related. Some aim at explaining the services rendered by the Department of Health and other organizations. Some about prevention of infectious diseases. Some are related to the geriatric related conditions such as osteoporosis and hypertension. I have no statistics with me now in regard to popularity. Well, the RCHEs would choose the topics, and the topics are chosen with regard to the resident population. For example, if some of them are suffering from hypertension, then they would tend to choose hypertension-related topics. Well, those who are you saying that those which are popular, you will keep them for 10 years? You also promote exercises and how to remain healthy. Of course, it's better to remain healthy than to see a doctor. Are you going to promote lawn ball and similar exercises? Introduction to the medical treatment should come second. Those from 65 to 70, they should get relevant information. It's said in paragraph 3.7 that you would regularly review the contents and update them if necessary. Perhaps you should provide more information on exercises. But of course, you need to make sure that there are suitable venues for them. Have you communicated with the venue management departments? I think the most popular is Tai Chi.
介紹之外咧，我哋有啲書或者錄影帶有得賣嘅，咁嗰啲咧都似乎幾受長者歡迎。
And also some other elderly exercises are popular. We actually encourage everyone to do more exercises. We promote healthy lifestyle jointly with the LCSD. I'd like to thank the member for suggesting that we should enhance this component. 3.8. Well, if the health promotion activities are conducted on Saturdays and Sundays, then the more family members will attend. Are you going to suitably adjust the timetable so that more health promotional activities are conducted during weekends and holidays? Well, we will certainly do that. All right, now let me turn to part 4. Sorry, since I'm already an elder, I cough a bit. Have you chosen your doctor?
咧講到有關呢個而家嘅
4.6, paragraph 4.6, and that is the ratio between doctors and elderly using the voucher. It can be 1 to 170, but it can be 7 times as much, 1 to 770. Since the scheme has been in place for some time, have you conducted a review so that you can address the disparity of the ratios? Can those living in districts with the ratio, or can you divert some of the resources from the districts with a low ratio, that is a 1 to 100 something, to those districts with a higher ratio? Since participation is voluntary, so we would like to attract more users through publicity. We did enhance our publicity efforts, and we also talk to the health providers or health service providers. Well, some think that the voucher value is low. At first, every voucher is $50, and that is if the total is of $80, they can use one voucher valued $50 and pay the remaining $30. We have introduced some changes, some improvement this year. The voucher value is now $2,000 per year, and the maximum accumulation limit is $4,000, and now they can use the voucher up to the $1. The lowest value for each voucher is $1, and we have tried to attract more service providers, more practitioners to join the scheme. In 4.9, Audit has recommended that the Director should continue to encourage more private healthcare service providers to join the voucher scheme. Would you consider giving awards to the best participating doctors, like a award scheme, so that the elderly can choose to see the better private healthcare service providers, and that will provide a contrast so as to attract more service providers to join the scheme. That would be better than just talking about promotion in abstract. I think you should consider more the proactive support measures.
方式喎。
係，我哋主要都係靠
Director, anything like a beauty pageant, well, we mostly rely on our promotion effort because in the course of commending those who perform well, we need to be careful because there are restrictions on promotion of doctors' businesses. All right, finally, 4.10, additional measures. That's what you mentioned, and also you step up publicity. And you mentioned just now that commercial promotion is not suitable for medical practice. So will there be any suitable organization with credibility to promote a wider recognition of the voucher scheme among doctors and encourage wider participation? Director, we plan that in the middle of 2015 to conduct another review on the ECHVS, and we'll also consider these points in our review. Kenneth. Sorry, Kenneth, please let Mr. Gary Chan ask first because this is his first round. Please switch on the mic. I think the voucher scheme is well received among elderly people because even my mother uses it, so it's a good initiative. Now, about part 4 of the report, I have a number of questions, but first of all, I need to point out one issue. There should be some indicators to gauge the success of the scheme. Of course, the audit has also provided some figures. For example, the number of elderly who joined the ECHVS, the number of enrolled medical practitioners in the private sector under the scheme. But I think we lack one quantifiable indicator. After many elderly people have joined the scheme, by how much can the waiting time in the public healthcare system be shortened? I don't think there is a scientific approach to keep statistics in this regard. Secretary, I believe you're correct. If you're referring to the extent to which the waiting time can be shortened, after elderly people join the voucher scheme, we don't have the figures. So after implementing the scheme, in future, if you could give us some quantifiable indicators so that the public would also know by how much the waiting time is shortened in the public healthcare system, it will be useful in assessing the success of this voucher scheme. Now, we spend $846 million on the scheme, and we need to gauge its effectiveness. On page 36 and 37 of the report, of the Chinese version of the report, it sets out in detail the nature and the details of the voucher scheme. Now, let me talk about G in page 38 of the English version, accumulation limit of vouchers. Now the accumulation limit is $4,000. This brings us to table 12. Table 12 shows elderly with unused vouchers and the amount involved. As at the 31st of December 2013, cumulative amount of unused vouchers amounted to $491 million. My first question is, will the cumulative amount of unused vouchers expire? Theoretically, I think the answer is yes. After enrollment, if the $2,000 each year are left unspent, then you've reached the accumulation limit, and in the third year you won't be given more vouchers. So why have you set the limit at $4,000? Because you have the budget anyway. This is a policy issue. Alright, so I won't pursue this. Another indicator is to pick up on Mr. Leung Sing's point. For example, the rate or the ratio of enrolled EMPs or enrolled medical practitioners, enrollment rates. There are different healthcare service providers with different enrollment rates in Table 9 on page 40 of the English version. And after enrollment, these providers may be subject to inspections and checks, and they need to do more administrative work. So what incentives do they have in enrolling in the scheme? Director or Secretary? Let me try to deal with this question on incentives for healthcare service providers. Not all would be attracted by incentives. Some may provide service for the purpose of facilitating the public. Doctors, in particular family doctors, may wish to get government's assistance, and this may serve as an incentive. And another incentive is that the voucher scheme would attract more patients. So initially, some doctors commented when the voucher amount was just $500 that it was too small, and that it wasn't useful. And when we raised the amount to $2,000, some doctors agreed that more patients would be attracted, and that in turn would become an incentive for doctors to join the scheme. So there are two prongs. Yes, there may be more patients, but on the other hand, they need to do a lot of form filling, and they're subject to checks. Yes, these doctors may serve the grassroots, but according to page 50-51 of the audit report, in relation to inspections, follow-up actions, these are administrative matters. Now, if I were a doctor and if I have provided services and then I would still be subject to checks, inspections, I would need to check if patients have completed all the forms. I just want to know whether it would be a difficulty for doctors. Director, we have regular inspections and we also follow up on any complaint received. If there are irregularities identified in the system, again, we will conduct inspections. For service providers, yes, we heard before that they found the scheme troublesome, and yet, as the monitoring authority, we must monitor and see if the scheme is not abused. So we conduct inspections, and when irregularities are identified, we look at the nature of irregularities. If it's minor, we will remind the provider. If it's serious, or if criminal liability is involved, we refer the case to police for further investigation. This may be an extreme case, but if the transaction is suspicious in your view, then the doctor will not be reimbursed. Is this prevalent? And do you have any figures? How many cases are involved? You can give us the figure later, Director. Well, just to pick up on Mr. Ng's point, the doctor has to serve the community and serve the patients. If the administrative work gets too cumbersome, the voucher scheme may become a disincentive. If a doctor performs well, I think we can give him something like a service label, just to commend his administrative work. Let's now refer to page 36 point in the Chinese version, point H. How to use the healthcare vouchers, and I'd like to talk about the e-health system. That's on page 38 of the English version. Each elderly person under the voucher scheme would be given an account in the e-health system, but it's only for accounting purposes. Is that right? Director, I'll defer to Dr. Lee to give you some figures first. For suspicious transactions, we have 1,953 cases as of October, the end of October. And they account for 1.something% of the total. So some with reluctance, I accept this, but we need to strike a balance. Yes, this is public money. Going back to the question, e-health system, is it just for the books, for recording transactions? Perhaps we can refer to Info 4. There was a paper submitted to LegCo explaining the e-health system. Now, to facilitate the work of the healthcare service providers, not much data is required for the e-health system. Basically, the identity of the elderly person and the transaction amount. I don't know whether it's an invasion on the patient's privacy. What are the stakeholders or users of the e-health account who has this information? There is a encryption code for users, so only the elderly person can check his own account and the outstanding amount. Who else? Our voucher scheme team would have different levels of authorization. So just now I suggested to the secretary that something should be done to show how much burden has been relieved in the public healthcare system after implementing the voucher scheme. The doctor should be allowed to choose the service to be provided, some sort of categorization of services. Maybe it has to do with the patient's privacy. We don't need too many details, but can you consider inputting this information in the system as well? Let's say in a year or in 1 or 2 years' time, let's say when you don't have to attend the PAC meeting, still you can explain to us that there were 100,000 physical assessments on elderly. But we already have the figure. We have this analysis in table 13. We found that for preventive care, it amounted to just a very small percentage, 8.8%, much more for treating acute conditions. But can you give a breakdown of this preventive care? I think for your classification system, you can give us more details. With the vouchers scheme in place, the patient can only wait for 2 months instead of 3 now, something like that. I don't know whether this is the appropriate term. Let's say if you could also classify the nature of disease or condition, this may help. You may wish to refer to RC 63/2 Info 4 for diagnostic information. There is some information here. Director, this is a paper prepared by Lechko, but it mentioned the purpose of the e-health system. One is for diagnostic information. Chairman, the computer system captures the particulars of the elderly transaction amount. Earlier, we heard members' suggestion that we should make a more detailed analysis. Can it be done in the system? We need to review that, because if we put in more information in the system, some service providers are already complaining of putting in too much information, too much work for them. So yes, we can conduct a survey and ask if it's possible to get more information, but I don't know whether it's possible to conduct a detailed analysis in the system. I think it's just a matter of one more mouse click, and maybe you have your own consideration. You mentioned 1,963 suspicious or problematic transactions. So what is your follow-up action? Is it that no reimbursement would be made after reviewing these 1,900 odd cases, or would there be another complaint mechanism and another team will deal with these 1,000 odd cases? Director: what we do is that we contact the service providers and see if all information has been provided. We also ring the elderly patient and verify if the elderly patient has received the service. It might be due to a typo, and this can be dealt with. And if the information recorded doesn't tally with the patient's record, then no reimbursement will be made. So among the 1,900 odd cases, there are cases in which the transaction will be verified on further investigation. Dr. Lee, these are unresolved cases after we go through the procedure for these 1,900 odd cases. All right, if there are no other questions, then we're going to conclude this PAC. I'm not saying that we're going to conclude the work of the PAC, but just on this part. Mr. Gary Chan, I wish to refer to Table 10 of Part 4. The reasons why some elderly people did not join the voucher scheme was that the enrollment rate of EMPs and ECMPs was not very high. And you can see that the number of eligible elderly was 737,000, but only some 2,000 EMPs and ECMPs. And I recalled, according to a survey, that the enrollment rate of ECMPs was relatively lower. And then after some publicity effort by the administration, now the enrollment rate of ECMPs has increased. And I find an interesting phenomenon in this table. For districts with more ECMPs enrolled, equally there are more EMPs enrolled. So perhaps the ECMPs have a different mode of practice. They may not have a computer, and that accounts for the low enrollment rate.
But if you refer to the computer records, it is 50-50. So how come there's a lower level of participation by Chinese doctors? What can we do to allow participation rate to be higher for both Chinese and Western practitioners? Secretary, I can provide some thoughts. Chinese and Western doctors, whether there are any limitations, and therefore they don't want to participate. I think for Chinese medical practitioners, it is about the hardware. Most Chinese doctors would not use computers. Therefore, they cannot participate. For Western doctors, they have different mindset. The current purpose of having the voucher system is to focus on preventive care and primary care and rehab services. It is difficult to identify the mode of operation of Western doctors in the community, because some are operated as family doctors, some as specialists. If they are specialists, some of them, especially those who perform more surgeries, first of all, the fees they charge, the surgeries they perform, and all the tests and checks required are very different from primary care offered in the voucher system. So there will be less incentive for such Western doctors to participate. And less elderly people will bring the vouchers to such doctors to seek primary care. So we're talking about 5,000 odd such Western doctors practicing in the private sector, and 2,000 odd are specialists. Some of them may use the voucher system, mainly for internal medicine or pediatrics. But there wouldn't be too much primary care offered. Of course, this would differ from specialty to specialty. So you adopted the angle of a doctor. When we look at the voucher, whether it is usable, we have to adopt the perspective of the elderly people and then make necessary adjustments so that we can fully utilize the vouchers. Most elderly people in Hong Kong would go see Chinese doctors. Unless they're very sick, they wouldn't go see the doctor. Sometimes they just go to the pharmacy and purchase some meds. So if we can attract more Chinese doctors to be registered, there will be real benefits. And when they go see Western doctors, they normally go because of more acute illnesses. In 4.16, there is the explanation. But you can see, if elderly people seek help from Chinese doctors, they cannot really use the vouchers, and they would think that it's better to keep them, and then eventually they forget. And they would forget there is a value contained in the vouchers, and they will be wasted. You have already allocated the money for the elderly people. Do you have a mechanism to remind them not to save them up? They are about to expire. Secretary, I have heard on the APIs on the TV concerning such reminders, but can your mechanism deal with this as well, Director? At the moment, we have increased the level that can be stored. We've done a lot of publicity work concerning the $4,000, and there is a cost if they want to monitor the situation. What about Chinese doctors? How can you enroll more Chinese doctors? We can do more publicity work, but as I've already said, if some Chinese doctors don't use computers, they cannot enroll. Chairman, I have two more follow-ups. Page 46. Which paragraph? 4.19. In the report, it says that some elderly people who have obtained the vouchers have already passed away, but the allocated sum has already gone to the DFH. So there is this phantom voucher. The person no longer exists, but the voucher is still there. So this is an error in the computer system. DFH will check on a monthly basis with the Immigration Department which elderly people have passed away, but the system fails to reflect this. The Finance Secretary, in allocating resources, the 100,000 deceased elderly will still get the allocation of 600 odd million. 262 million. So where has the money gone? Is it being spent? If it is, where is it going? Or if it is unused, is it going to flow back to the Treasury? If it is not used, it is in the account, it will not disappear. The money will go back to the Treasury. Secretary, can you tell us, every year, do you deduct the number of deceased elderly before you approach Finance Secretary, Director? Last year, because of accounting reasons, the money for deceased elderly people was released. For this year, we have already resolved that. For 2014-15 estimates, the money will flow back to the Treasury for central allocation. Are you talking about the 92 million in 4.20? Can I ask the director to tell us again? Every year, concerning the vouchers, how much will go back to the Treasury? Director, you don't have it? Maybe you can provide it later on. Yes, you can provide written reply because it's quite complicated. Mr. Chen, final question, 4.34. There would be some mistakes. Many doctors will ask the elderly people to fill in blank forms. This could lead to possible abuse or theft. And if you refer to table 17, there are more than 1,000 such cases, errors and omissions. I remember there was one report. One Chinese doctor told the elderly person to fill in the voucher, but not for seeing the doctor, but purchasing some seafood products. It really did happen, so it proves that there are loopholes in the system. So I'd like to ask the department, what can you do to plug such loopholes? Filling the vouchers in advance. Anything else you can do to improve this report system or claim system? Director, perhaps it's very difficult to achieve 100%. Table 17 and 4.34 lists out the omissions and the errors. There was one case involving a service provider, one Western doctor, under 4.34. In the past, every unit is $50. If the person spent 200, there would be one consent form, but the doctor asked the elderly to fill in 4 consent forms. We have reminded him, and he has stopped doing this. For table 17, containing errors and omissions, we will follow up case by case. Our staff will contact the service provider and also get in touch with the service recipient to check medical records against the memory or records of the elderly person to ensure the services were delivered. And if everything matches, we will transfer the money. We will target those providers with more frequent omissions or errors or unusual transactions, for example, certain surge in level of services provided in one single day, or abnormalities compared to other service providers. We will choose some of the cases for further inspection. No more follow-up. Mr. Alan Leung, on this part, Chairman, concerning the medical vouchers, Mr. Chen already asked about a case where a Chinese doctor asked the patient to buy seafood. If you look at 4.34, you can see that some cases are quite outrageous. It says when an elderly person went to see a doctor and signed 59 such forms, the Department of Health has noted this case. What follow-up has the department done? Director? We have already followed up on these cases. Dr. Lee, can you tell us the details? This Western Doctor number 4. In the end of November, we paid a visit to his practice again. He has already stopped such practice. Do you have any guidelines? They shouldn't ask elderly people to sign such blank forms. Dr. Lee, we have accepted the recommendation of Audit Commission, and we will do more to remind service providers not to do so. Especially, we have switched over to $1. It's impossible to ask someone to sign 200 blank forms anyway. In the past, it was $50 per voucher, and he misunderstood that for every voucher, consent form will have to be signed. 4.23 says, Chairman, Department of Health will monitor voucher claims by adopting a post-payment approach. So providers are required to submit claims online through the e-health system. After receiving the claims, the DFH will make payments in about 1 month and conduct inspections later on to verify the validity of the claims. In 4.38a, you would see that the Director of Health agrees with the audit recommendations. She has said that the DFH will consider reviewing the inspection protocol. What direction is this review going to adopt? Concerning the current protocol, do you see loopholes that you want to plug? Director. The Audit Commission pointed out that our inspections would involve advance notice to the service providers. They suggested that we can do surprise checks, so we're going to add surprise checks in the future. Understood. 4.38b. Director also agreed with the audit's recommendation. It would take measures to enhance service providers' compliance with the requirements, including issuing guidelines for them on the proper completion of consent forms and issuing advisory letters or warning letters where warranted. On this point, can the Director explain to us what new measures will be implemented? And how they will operate. 4.38b. During the pilot run, we wanted to encourage and educate service providers to do better. So if we notice any problematic filling of the forms, we would provide advice, and then we will keep a record. We accept the audit's recommendations. This is now a regular scheme and will be more stringent. If there is no improvement, we will issue advisory letters or formal warning letters. Alan? When do you issue advisory letters? When do you issue warning letters? Director? That depends on the situation. Sometimes mistakes and omissions are very minor in nature, and some others are quite serious in nature. So it depends on whether this is the first time they make such omissions or errors or repeated offense. Alan? Issuing advisory letters or warning letters are not new measures. Are they already in place at the moment? This is going to be new. In the past, we will just record things on our inspection records. Before we do the fire drill, subparagraph C, you agree to follow up audit's findings on consent forms. This follow-up, how is it going to be done? What about the results? Do you have the results now, Director? According to the cases listed, we have visited the service providers to inspect their record. Most of them have been checked and there's no evidence leading to fraud. A small amount of records are being checked at the moment. We have completed most of them and there's no fraud involved. Okay, finally, 4.41. It says that Director of Health agrees with the audit recommendation, and the administration already has plans to conduct an evaluation of the voucher scheme in mid-2015 after the enhancements in 2014. Have you thought about this evaluation? What direction are you going to adopt? What about the content of such evaluation? Do you have any timetable? Director? Chairman, the content of the evaluation will make reference of the first interim report and the content therein. For example, mode of usage, number of participants or users, and through some sort of investigation we can interview service providers and service recipients why they use or choose not to use the vouchers. We have yet to devise all the details, and we would like to start the investigation by mid-2015. Alan, nothing else for part 4. So next time we'll move on to part 5. Today we don't have time for part 5. Can we do it after the fire drill? No? Then let's not do it. Can you allow me to say something, Chairman, so that the Secretary can be better prepared before they come back for the next session? Concerning the specialist outpatient service to elderly patients covered by Part 5, once upon a time in public hospitals there was this geriatrics department, and that is part of the internal medicine.
From value for money audit perspective, I hope the Secretary can explain to us next time whether subsuming geriatrics under internal medicine would be the best way to utilize the funding approved by LegCo, or should we have an independent geriatric specialist service? So I just want to give the Secretary a heads up. I don't think this falls within your portfolio, but please get ready for the next session. Well, I'm not going to ask questions on the policy. I want to know whether this is effective utilization of funding. All right, thank you all for coming to our hearing. I want to thank the Director of Audit and his team, as well as Dr. Koh and his team. Next time, HA and I would attend. There would be no need, I suppose, for the D of H to come. Yes, certainly you are correct. We would ask questions in writing if necessary.